Is Teresa on the call? Okay. Then is somebody from the department of Dawn? Do you have a list of members that you could do roll call?
I'm happy to do that for you, Dr. Barton.
Okay, thank you.
Yep, and we continue to remain lost with Charlie not here, so bear with me. I pulled up the most recent list that I have, and so Nina Eisner.
I'm here.
Susan Stewart.
I'm here.
Brian Proctor. Okay, and you mentioned that Peggy was not going to be here. Dr. Jerry Roberts.
I'm here.
Teresa Aldridge. Eric Wright.
It changed the whole thing, but I got it there.
You mentioned Dr. Bobrowski is going to be late. Dr. Steve Copton.
I'm here.
Oh,
Bobrowski's
you are.
here.
You are here. Okay, great. Thank you. Dr. Steve Compton. I think I saw him. Yeah. Dr. John Mueller.
Here. Mueller here. Yes.
Mueller. I'm sorry. My apologies. Dr. Ashima Gupta. John Dadds. Dr. Cat. Oh, thank you. Dr. Catherine Hanna. And Tyler Morgan.
Here.
Barry Martin.
I'm here.
Thank you. So you have, I think I counted 10, if I counted that correctly, which means you have a quorum.
Great, thank you. Before we get started, there's just one thing I wanted to mention is under new business, I've added another item, which is the meeting dates for 2023. I forgot to put that on the agenda when I sent that out. So getting started, we'll go to old business. And first up is, has any work been done on the Medicaid regulations to reimburse certified professional midwives or CPMs?
Dr. Parton, do you want to approve the minutes first from September?
Okay, sorry, thank you. Can we have a motion to approve the minutes for the September meeting?
This is Nina. I'll make that motion.
Okay,
I just think I'll take it.
okay, who was that?
With Kathy Hannah, second.
Okay, any discussion? All in favor, say aye.
Aye.
Aye. Aye.
Aye.
Any opposed? Okay, so moved. So we move on to old business then. And then, as I said, the first item up is, has any work been done to amend the Medicaid regulations to reimburse certified professional midwives or CPMs?
Hi, this is Veronica Cecil with Medicaid, and we have not moved forward yet with making those changes. I think Dr. Terrio, Judy Terrio, our medical director, will be presenting a little later in the meeting. This is under consideration as part of changes that we plan to make as a more of a comprehensive program for improving maternal health. So the answer to that is, as of right now, we've not yet filed any regulations.
Okay.
This is Nina. May I ask a question? Has that recommendation actually been approved from the MAC to the cabinet? I know we've talked about it. I couldn't find in my notes that there's actually been a recommendation from the MAC.
I don't know. I'm not. Yeah, I'm not aware.
We've had it on the agenda for probably the whole of this year, but I don't know that officially we made a recommendation. I don't recall if we did or not. I think
I'm just-
go ahead.
I was just gonna say, it has been on for a long time. I was just trying to understand procedurally. I thought there had to be a recommendation from the MAC for actions like that, but if I'm wrong, I stand corrected.
Okay, I don't know that there has to be an official recommendation, but if you'd like to do that, we can put that forward. The department has responded each time it's been on the agenda.
Yeah, and it is included again in you know, what we're trying to do around maternal health.
Okay. Well, then I don't think we need anything further.
Okay, thank you, Nina. Okay, next up is requested amendment to the Rural Health Clinic Regulation 907 KAR 1:082, Section 91B2, to extend the time to 3 days for providers to sign Medicaid participants' charts. The current regulation requires charts to be signed on the day services are provided. 3 days would be in line with other regulations and more realistic in a busy clinic. So where are we with that?
The department anticipates filing those regulations in January. We are still working because we do want to align that requirement across the entire program. And so that does affect a lot more regulations than we originally anticipated, but our goal is to have that filed in January.
Okay, all right, fine. I'll put it on the next agenda. Okay, Judge Philip Shepard in Franklin Court ruled in late April that the bidding process, which was the second one for awarding MCO contracts, was flawed and must be rebid. What are the immediate and long-term effects of the judge's ruling that the MCO contracts be rebid, and how does DMS plan to proceed?
This remains under appeal, which means that, you know, the department is not moving forward. My recommendation for this, Dr. Parton, is that because that appeal process could be quite lengthy, we'd be happy to provide updates around this in our update if there's a change in circumstances.
Okay, okay, fine. I'll take it off the agenda then, and I will just wait for DMS to provide us an update.
Got a question. This is Dr. Bobrowski. Is Ms. Veronica, is there any way that, of course, we've got it listed down that the contracts were flawed. Is there any way we can find out what he was considering as being flawed in that part of it, or is that public knowledge, or what about that?
Well, I mean, the Judge Shepard's decision is public. So certainly anybody has access to that and can read it as to, you know, the reasoning behind his decision. But I will point out that, you know, multiple entities have filed an appeal, and so it is right now pending at the higher court level.
Thank you.
Okay, then an update on missed or canceled appointments. How is the reporting going? Are there any concerns or common threads as to why patients are not showing up for appointments?
I think Lee Geist, Director for the Division of Policy and Operations, might have some information to share.
Sorry, I couldn't get my video on quick enough. Good morning, everyone. This is Lee Geist. And the reporting is going well. They're being automatically distributed to the MCOs on a monthly basis, but there is still no common thread other than the reasoning. Usually the reasoning is they don't know. So there's no reason given.
Okay,
But we are able to send the Medicaid IDs to the MCOs. And I know that one of the MCOs, I was in a meeting, an operations meeting in the last couple of weeks. They were talking about how they were using the file and marrying it up with their chronic disease folks, et cetera, to try to get a little bit better handle on care management.
Okay. Will there be any in the future, any way to get an idea about why people are missing appointments?
Well, if you would make a request to see that information as far as de-identified the reasons and the numbers, I feel sure that we could provide that if you made that a request of the department.
Okay.
Dr. Hart, I just maybe want to clarify what you're seeking, and that is the reason why the member did not attend. I think, as Lee mentioned, a lot of this is bucketed under I don't know, because they don't know why the member didn't make it.
Yes.
So, I think it would be difficult for us to report back once the MCOs have the information and are hopefully doing some case management around their members, making appointments and seeking care. I think it'd be hard for us to report on that more individual level as to what happened. I think we're, as a department, excited that we have this tool to assist in identifying gaps in care and as another way to help outreach to individuals about what could be the reason why they're not able to make the appointment. So transportation, childcare, there's this could very well be a good tool for our MCOs to really figure out what's going on. I just think it might be difficult for us to report back on that.
Okay. So what you're saying is that the information will be given to the MCOs, and then the MCOs are to reach out to their members to try and ferret out what the problem is.
That's
Yes,
correct.
ma'am. Yes, ma'am.
Yeah.
That's exactly how the report is used, is that there is it's an automated report. It gets sent monthly. I get copied on it just to verify that it gets released. But yes, they get it. They get the reasons, they get the dates, and they get the Medicaid IDs in order to work with it. Work
Okay.
with their members.
Okay. So would the council be interested in maybe getting a report from the various MCOs, maybe in the next 2 meetings, to see what they've done and what the reasons are for missing? I think that would be really helpful to the practices if we knew some of those reasons. And then maybe, on our end, we can do something as well.
This is Barry, and I really feel like that would be very helpful for providers to get that information, and also for the MCOs to help encourage patients to not miss their appointments, because of course there may be transportation issues, but there just may be just lack of interest of keeping your appointment. So it'd be nice to know which one is which.
Right, exactly. So would it be the pleasure then of the council to maybe at our March meeting to have a report from the MCOs about what they've done and what information they've been able to garner regarding missed appointments?
I think so. This is Barry again.
Nina, I agree.
This is Ashima Gupta. I agree as well.
Dave Compton, I agree also.
Okay, anybody disagree? We'll make that a little easier since we're not in person. Okay, so I will put that on the agenda for January, just as a reminder, but that in March, we will get a report from the MCOs. And I'm writing this down, so excuse me. And so,
I'm sorry, excuse me.
Did you say the report would come from the MCOs?
Yes, that's what the MCO, the DMS is sending the information to the MCOs
Yes,
and
ma'am.
are to reach out to their members as to why they're missing appointments. It's my
Right.
understanding.
Thank you.
Yeah, again, I think it's fair to ask the MCOs to come and talk about what they're doing with the information. You know, certainly give examples of that.
Okay, so I'll keep that on the January agenda, just as a reminder that in March, the MCOs will report. And will somebody from DMS be reaching out to the MCOs to let them know that we want them to provide us information on that at the March meeting?
Yes, we will make sure that that invitation gets extended and the expectation for them to present.
Okay, thank you. Okay, at a previous meeting, we decided to continue Zoom meetings through the end of the year. And that at this meeting, we were going to discuss how we would continue in 2022. I know there's some factors related to the setup in Frankfurt as far as us meeting safely because of the number of people who want to attend. So I guess it's a two-pronged question here as to what members of the council would prefer to do and what they feel comfortable with and what accommodations are possible if we were to return to face-to-face meetings. So I guess first of all, what is the pleasure of the council? Do we want to in January meet virtually or in person?
This is Garth Bobrowski. We had our TAC meeting this last Friday, and I know some of the folks there in Frankfurt kind of talked like that they really may not be set up, I guess, technologically for us to, you know, to do kind of a hybrid thing, meeting through maybe the first part of next year. My recommendation would be just to continue with the Zoom. It just kind of sounds like they're not quite ready for us to meet in Frankfurt just yet, but and maybe Miss Veronica can add more light to that, but I'm just going off what we discussed the other day at our TAC meeting.
If I could ask a question, I'm curious. I mean, Zoom is so convenient. We've all learned to live with this. Has going to Zoom virtual versus being in person changed the attendance of the council members or the participants? Because, I mean, I think that's something we should consider. I don't know what the answer to that is, though. Has it improved things?
Yeah, I can tell you from the departments, certainly being, you know, working with all the tax and the MAC, there has been a definite increase in the number of participants, both from the members and from the public with the virtual. What Dr. Bobrowski was talking about is, and I think we've mentioned this, is we're in the process of procuring the capabilities to make it what I would say probably the best mix hybrid of an in-person and a virtual, so we can continue to extend that opportunity to folks across the state. So we're procuring that. We aren't ready. Unfortunately, I don't have a date when that's gonna probably be available. The other thing I want to mention is, you know, with the session going in January, we'll have limited availability of LRC meeting rooms. And so we always have to work around that as well. So there's that impact too.
Okay, so it sounds like for the next couple of meetings, at least for January and March, that we should continue with Zoom and then maybe talk about it in March again, see where we are with COVID and see where we are with the facilities to to allow in-person meetings. That sound
I,
fair?
I would agree. I would agree with that, Beth. I think maybe circling our May meeting as maybe being the first return to in-person. I think that's very reasonable.
Okay. So then we will meet virtually in January and in March. And in March, we will revisit the issue again. Sound fair? Okay, anybody opposed to that? Okay, thank you. Make a note here.
This is Ashima Gupta. What are the dates for, do we have the dates listed for next year?
I put that, I forgot to add that to the agenda, and it's at the end, but I'll tell you
Okay.
now, it'll be the same. It'll be the fourth Thursday of every month, except for November, which will be the third Thursday. And I didn't look on the calendar to see what those dates are.
Every other month, right?
Right.
Okay, thank you.
Okay. Let me make a note here. Okay, next on the agenda, the telehealth rules after the emergency state ends, platforms to be allowed, and any other updates regarding telehealth.
The department did file its regulations on October 15th. So they're out there and available for review. We do want to just remind folks that, you know, we're limited to those platforms that are approved by the Office of Civil Rights. And so we have to remain in compliance with that. That being said, you know, we really want to continue to have providers utilize telehealth as a way to increase access. We're very supportive of that. We'll continue to be supportive of that, but our regulation is out there for comment right now.
Okay. Veronica, can you tell me what regulation it is, the number?
Yes, 1 second, sorry. I closed it. Hold on 1 second.
Sorry.
No, that's okay. I opened it to look at the date that we filed it. It is 907 KAR 3:170.
Okay. Thank you.
You're welcome. And I'm happy. I'll put the link to that in the chat.
Okay. And speaking about the regulations, I didn't have this on the agenda, but I wanted to thank the department for working on the regulations so timely, and also the regulations that will put into to enable the statute that was passed to allow nurse practitioners to continue to order home health. That's very helpful. Thank you.
You're very welcome.
Okay, next up, there was a recommendation from the dental tech at the last meeting. And I wasn't clear on the question when I went back to look at it. Was the dental tech asking for the reimbursement of every provider in every county, or just the gross amounts per county? I guess somebody from the dental tech would need to address that.
No, this is Dr. Bobrowski. Once before, we had gotten a report, and it was listed as per provider. What we're looking at is trying to figure out this access to care. We're just seeing a lot of locales that just don't have a dentist listed. Don't have a dentist that's accepting Medicaid, but they're still listed on the rolls that they are a provider. So we were just trying to shore up some things and get access to care looked at. So the original documentation was per provider in each county.
Okay. I guess I have a little bit of concern about showing what the reimbursement was received by every provider. I don't know if there's any harm, but it just at first blush, it just feels to me a little bit invasive, maybe. I don't know the right word, actually, for providers sharing exactly what they were reimbursed from Medicaid.
Dr. Parton, in our response to the dental tax recommendation for this data, we did indicate, and what we're looking into is how can we report that? Because you do have to be careful about proprietary, confidential rates negotiated between a provider and the MCOs. And so, and I think Dr. Bobrowski is aware that we're trying to see at what level we can provide that. We're not sure we could do it at the county level, especially if there's just one provider in that county. So in terms of the reimbursement, reporting the reimbursement amount, we are looking at, what we are able to report. So we kind of share that concern about, making that information available.
Okay.
But we're still trying to be responsive to the dental tax and the information that they want to receive.
Okay. It seems like maybe that information could be received without reporting exactly what everybody was reimbursed. Because it sounds like Dr. Bobrowski is looking more at access to care, which is a huge problem in my area, because the dentists are not accepting Medicaid patients. And so they're coming to primary care providers who can't do anything except maybe provide an antibiotic if they've got an abscessed tooth, and that's it.
Well, and one way to do that is just to report claims as opposed to amounts, reimbursement amounts. And so that's what we're looking at, is what can we do to get the dental tax information that they need. And we understand that, because we understand that that's one way to look at access, is to really see who actually is performing services and seeking reimbursement. So we're doing our best to try to balance that.
Okay, thank you.
This is Ashma Gupta. I have a question about related to that. So if a provider contracts with Medicaid, and can they refuse to see Medicaid patients? Like, I'm wondering if those like dentists that are on the, on the list of the MCOs to be providers, but then when you call them, they say they don't accept Medicaid. Do we know if those providers actually are contracted with Medicaid?
So there's a couple of things to note. One is that a provider could be enrolled in providing services of fee-for-service, but don't have to be contracted with a managed care organization and provide services to the managed care population, and vice versa. So if a provider wants to enroll and only provide services to the managed care population, they can do that. They're not required to provide services to fee-for-service. So ultimately, I guess overarching is a provider does have discretion in, we can't force providers to take members. They can't discriminate against a member, but certainly a provider can make the decision as to whether or not they're going to see or how many members that they are capable of seeing. So those decisions do rest ultimately with the provider.
Okay.
But I will also share that we do have requirements and criteria to meet the definition of a provider and what can be considered in network, as part of their network adequacy. And we're continuing to do our best to make changes to that so that it is truly reflective of the providers that are available and are accepting members, and are they full-time, especially if they're in that county, if there's a provider that's going to multiple counties, that splits their time up. So we are continuing to dig down into the data to make sure that that's all accurate, and we're monitoring that.
Okay, thank you.
Okay, anybody else have any comments? Okay, then moving on to the next item is incentives for vaccine. We discussed this a little bit at our last meeting, just in general. But lately I've received more specific information from some of the patients that I see regarding incentives. And excuse me. I had a little bit of concerns about one of the MCOs was Anthem, because their incentive, they sent a letter to the patient, but in order to access the incentive, the patient had to have a computer or a smartphone. And some of my patients, and I'm sure some of other providers' patients, do not have smartphones or definitely do not have computers, and or even know how to use those things. Even if you said you could go to the library, a lot of my patients, even if they went to the library, wouldn't know how to use a computer. So that was one barrier to receiving the incentive. And then another thing was that the patient, one particular patient of mine, brought their card or their letter to the clinic asking how to access it. And even though there was a phone number, you still had to have a computer. So we did that for the patient through our computer system. And then when we got to the incentives, they were things like a coupon to get goods from Barnes and Noble, or some restaurants that are only available in urban areas, or for items to some fast food restaurants that we don't have in our community. And so the incentive for my patients who have Anthem was really not an incentive at all. One, because they couldn't access the incentives, and two, because we don't have those places in rural areas for people to use the things that were listed as incentives or coupons for the patients. So on the other hand, United Health automatically sent $100 debit card to patients that they could use in any way they wanted to. And this was very helpful. One of my patients told me that she was using it to pay for some of her utility bills. But again, the letter wasn't clear, and she thought that the card that she received was a company requesting her to sign up for a credit card. So I think that incentive was very helpful, but not very clear to the patients who received it of what she could do with it. But once we helped her to understand what it was, she was very happy about it, and it was very helpful to her. So I just thought I'd bring that up and see if anybody else had any other comments. But I really wish if the MCOs, if they're going to provide incentives to patients, and these were incentives to get the COVID vaccine, would provide incentives that would be realistically helpful to the patients.
This is Stuart from WellCare, if you don't mind, talk a little bit about that.
Sure.
And we've learned in all MCOs, believe me, we've thrown out a lot of incentives. There's not a lack of incentives, but what we've discovered is the most effective. It has to be something immediately available. For example, something for the promise of 2 to 3 weeks from now, they're not going to sign up for it. They're not interested. The Disney World, which all the MCOs have combined together to offer free vacation to Disney World, hasn't worked as well. We've even, WellCare offered to come in home. We've got initiatives where we're going home. We've been disappointed with that. But the most effective which was all MCOs, all of us. We had a booth, our association, Kentucky Association of Health Plans at the state fair, where right then and there you got a Walmart gift card and you got a bracelet giving you admission to the Midway, which was the rides at the state fair. And we had, I believe it was 550 individuals at the state fair that got shots right there because of that. And that was definitely the most effective incentive. But that's what we've learned. If it's something that they've got to wait for, they're not as likely to do it. And I talked to our member outreach director, who's a long career in marketing, and he said this has been the most difficult marketing challenge he's ever faced. You have in some areas of the Kentucky rural areas are just distrustful of outsiders. And of course, all the stuff around the COVID vaccine fears or whatever. But there are definitely, all the MCOs I know have thrown out a lot of incentives out there.
Thank you for that. Yes, they have.
Sure.
I guess my point being that the incentive should be timely, as you said, but also something that is useful and accessible to the patients, especially I know in my rural area, people don't have computers or a lot of people don't have smartphones. They have a flip phone. And so they can't access those incentives if they have to use a computer. And then the information to the patient needs to be clear as to what it is, because I can't tell you how many patients bring letters to me asking me what this means because they don't understand the correspondence that they receive.
I would like to add that there is that benefit out there for smartphones, I believe through the Lifeline program through SafeLink. I know not all the members do. It's always an option for Medicaid members if they.
Yes, and that's helpful. But again, some of my patients anyways don't have the education or the understanding of how to even use a smartphone.
Understand.
This is Dr. Bobrowski. I got a question for Stuart Owen, please. Did I hear you correctly that one of the benefits of going ahead and getting the vaccine was a vacation to Disney World? Did I hear that right?
Yes, that all the MCOs partnered up with that through the association to offer that. But we haven't had as much interest when it's something like, because that's kind of like a lottery, a chance or whatever. That just doesn't generate, you'd think, sure, why not? But it hasn't generated near as much interest as we thought that it would.
Okay, thank you.
Dr. Parton, I think this is a really great feedback, and it reminds us about the population we serve and how we need to do better in making sure that they have real access to programs like this. We will definitely take this back and regroup with the MCOs on what changes can be made based on the feedback. I also wanted to mention that we have created a document that has all of the incentive programs across the MCOs, and we're working to make that easier to understand. And then we're going to post that so that it's out there and available, and keep that updated. But I definitely think a part of that is going to be what's an easy way for members to access these incentives.
Thank you. That would be very helpful to me to have to help explain to my patients, because I'm not aware of all the incentives. I looked some of them up specifically regarding the vaccine, but if something was readily available to help us explain to our patients, that would be helpful.
Absolutely. Well, as soon as we have that created, we've got a Word document, but it's not very pretty and not easy to navigate. So we're kind of trying to turn it into like the open enrollment value-based visual that we have because it's by MCO, and I think it's clearer to see, you know, what's being offered and how to access it. So as soon as we get that done, we will send it out to the MAC and the tax, and then we'll post it online so everybody has access to it.
Great, thank you. Does anybody else?
Yeah, this is Jeremy Randall with Anthem. Just one quick comment. First of all, you know, this feedback is invaluable and really appreciate it. Our members are able to order the incentive over the phone. So, you know, smartphone or computer is not necessarily required. They can call our member services. But, you know, your feedback about, you know, the specific types of gift cards available, you know, that point is well taken, and we'll take another look at that. Thank you.
Thanks, Jeremy. I have to say that the Anthem in particular, when we have the patient trying to access that, we tried calling on the phone for the patient, and they told us that we still had to have a smartphone or a computer to access the incentives. Even though through the phone call we could find out what they were, they still weren't accessible unless you had a smartphone or a computer.
We will look at that urgently. Thank you.
Thank you. Okay, does anybody else have anything under old business? Okay, then we will move on with updates from the commissioner.
Well, and so I'm not the commissioner. She extends her apologies. She had a conflict with the meeting today. So I'm going to do my best to fill her shoes. And she did want me to mention that she attended the National Association of Medicaid Directors conference this week. And it sort of renewed her enthusiasm to support some of the shared priorities with CMS around access and enrollment, around equity, and as well as accountability and transparency. And, you know, under her leadership, we are trying to make some significant changes in the program to move towards data-driven, health outcome-based policies, and working more closely with the provider associations and the MAC and the tax on how do we drive quality and how do we work together to do that. So she did want me to share that. I wanted to announce a couple of staff changes. One is that Leslie Hoffman, who has been serving as an executive advisor or behavioral health senior policy advisor, has been named deputy commissioner. So she will now take over that role. Dr. Fatima Ali had been serving as interim pharmacy director, but I'm happy to announce that she has been, we're taking that interim title off, and she is now becoming our full-time pharmacy director. And just also want to recognize that she did a phenomenal job with the implementation of the single pharmacy benefit manager in July. So we're so thrilled to be able to have her officially take over as the pharmacy director. Wanted to announce Rick Washabaugh. He will be joining as an executive advisor on December 1st. He will be coming from the Cabinet's Office of Technology, Application Technology Services. Rick has been leading the work around what's called the requirement that we're required to have with CMS. It's advanced planning documents. That's the funding mechanism to pay for all of our IT and data systems. And so Rick will be joining the department along with moving many of the folks from the Office of Application Technology Services Division of Medicaid Systems we will be moving those folks over to Medicaid as well. And we're doing that because we really want to renew, again, our focus on using data, having good data, being able to share that data, and having those folks directly under Commissioner Lee and the Department for Medicaid Services, I think will reinforce those priorities. As you all know, open enrollment is continuing through December 1st. As of yesterday, we've had 7,055 MCO changes. So wanted to report that. And also just a reminder that the Health Benefit Exchange open enrollment started on November 1st and runs through January 15th. Wanted to share that I believe we announced in the last MAC that we were applying for a grant around mobile crisis. And I'm happy to announce that we did receive a state planning grant. These are funds through the American Rescue Plan Act, and DMS in partnership with our sister agency, the Department for Behavioral Health, are going to work to develop an alternative response model to shift behavioral crisis response from law enforcement and first responders to well-trained, qualified, multidisciplinary teams. So we're really excited about where this could go in terms of helping with behavioral crisis individuals impacted, through crisis across our state, and get them the care they need, and to try to even intervene a little earlier. We're also we started last month on our technical assistance around a SMI SED waiver, and that will continue over the next couple of months. Some of you may be aware that there is an LRC SMI task force, and they just issued recommendations yesterday. So we'll be definitely taking a look at those and let that inform some of the work that might come out of that technical assistance. Our certified community behavioral health clinic demonstration, otherwise known as Ccbhc, it appears that we will be able to launch on January 1. This is a demonstration that sort of changes the service and reimbursement model around behavioral health. And we're excited to have 4 of our CMHCs that are participating in that. And then the Kentucky Level of Care System, otherwise known as CLOCS, we will be starting a pilot at the end of the month around telehealth initial assessments. We hope that this pilot will show a way to reduce administrative burden and to increase more timely access to nursing facilities, to institutional hospice facilities, and to ICF IID facilities. So that's going to be launched at the end of the month. And for my next update, I would like to turn it over to Pam Smith, Director for the Division of Community Alternatives, who's going to give us an update on how we plan give us a status on where we are with using the American Rescue Plan HCBS funds.
Thank you. So we received our initial partial approval, which is similar to what most states received to the initial spending plan that we submitted to CMS for those enhanced funds. We have since responded back to CMS to answer the questions they had. Most of them were more clarifying questions or about the process of how we were going to do something versus anything about any of the initiatives that we were planning. So biggest activity right now is we're working on the project plan and aligning all of the teams to carry out those. We will begin having stakeholder engagement sessions. I'm hoping to be able to have a couple in December just to give high-level updates. And then beginning in January, we will do something kind of similar to the model that we did with waiver redesign, where we will break out some of the initiatives so that we make sure that we continue to have stakeholder input, whether that be the provider, it be advocates, or it be participants themselves or individuals that support them. We want that to be a diverse group to make sure that there's opportunities for stakeholder involvement in all the initiatives and transparencies for those. But we will be posting on the website those dates, as well as sending it out to the distribution list of all the individuals that have signed up for updates for the waiver. But we're very excited. I think we have some great things that we have planned that are really going to benefit the individuals that we serve and our providers.
And other than we've got over 50 projects that we're working on across the program, that's kind of the update for today. I'm happy to take any questions.
Veronica, what's the total enrollment in Medicaid now?
I can get that to you, just one second. I believe it's like 1,500,000, 1,578,062.
Thank you.
Is that pretty consistent?
Yes.
Okay, then if you don't have anything else, then we'll just move along to the TAC reports. Thank you very much. Okay, so moving right along. First up is behavioral health.
Good morning. How are we doing, folks? This is Steve Shannon filling in for Dr. Schuster. Briefly, we had a meeting November 1. We had all 7 members participating, as long as several state agencies, MCOs, and other advocates. We welcomed a new member from the Brain Injury Alliance. And we approved the minutes from the previous meeting as well. We discussed ambulance transportation with the Kentucky Hospital Association, continue to work with that group to see how we can help resolve some of the issues of transportation between hospitals. We got an update on the SUD waiver. We've heard a lot about that, the substance use 1115 waiver for people who are incarcerated. Looking forward to that. Update on the SMI task force. Their reports, as Deputy Commissioner Cecil shared, were released yesterday, and we're waiting on the 1915C because some of our members serve brain injury services, so we want to see that task force report as well. Some concerns were expressed about the number of audits that MCOs are now conducting at different providers. Several CMHCs have seen requests for a lot of records in excess of 200-300, and it was recommended if anyone has concerns, they should reach out to Angie Parker at Medicaid. We approved our schedule for 2022, the second Thursday of January, March, July, June, September, November. We also had a big discussion of dual eligible. This has been an ongoing concern the TAC has looked at. There is now a bypass list for people who are both Medicaid and Medicare eligible. We appreciate that. That should help as well. But there are some concerns about folks who are dual eligible with commercial insurance and Medicaid. So a recommendation we have relating to that is request that Kentucky Medicaid gather data on behavioral health services which have been denied for third-party liability by commercial insurance carriers over the past 2 years in an attempt to determine the top 10 services which were not covered by commercial insurance carriers, but should be covered by Medicaid. And then perhaps create a bypass list for those services that commercial insurance do not cover. So let's focus on all services by commercial insurance, focus on the top 10. And I think that was submitted in writing as well, so you have that recommendation. But our goal is to see if we can minimize folks who are denied, who are not, services that are not being paid by commercial insurance, but Medicaid should pay because we don't receive an EOB. Our next meeting is January 6th. Appreciate the opportunity. And Chair Parton, if it's okay with you, can I jump ahead and briefly do the persons returning to society TAC report? Because I'm here and supposed to be 2 other places. Is that okay?
Yeah, is that a new TAC?
Yeah, we reported last month as the persons returning to society from incarceration. So this is, we actually had a couple meetings and the report's brief because we're going to meet the second Thursday, which was Veterans Day. So we didn't meet. We're going to try to move it a week. Today's the max. So we essentially haven't met. We'll meet in December and then again in January. And that's all the report. Thank you.
Thanks, Steve.
Appreciate it.
Okay. Okay, next up then is Children's Health. Okay, Consumer Rights and Client Needs.
Good morning. I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health, and I chair the Consumer TAC. We met on November 16th, so just this past Tuesday, due to some scheduling conflicts that we had in October, and we did meet remotely and had a quorum. We had an abbreviated agenda because this was rescheduled, so we focused most of our time on open enrollment and the rollout of our state-based marketplace, which is now fully reintegrated with Connect, which is really exciting. Medicaid open enrollment, as we all know, began on October 15th, along with a soft launch of that state-based marketplace, so that reintegration piece. And since then, connectors have quickly noticed that the reintegration has caused some system issues that have been making it more difficult for them to access their clients' applications and electronic notices. And of course, that makes it more difficult for them to provide timely assistance to folks. So this is affecting not only people who are applying for marketplace plans, but also potentially applying for or recertifying their Medicaid plans, or trying to make some changes and even select a new MCO. But primarily it's affecting the enrollment and the recertification. And this is especially true now that mail is taking longer to be delivered. So when people are getting notices in the mail that are either coming just right at the deadline or even sometimes after the deadline, they don't have a lot of time to be able to respond to that notice and submit whatever the required documentation is in order to complete enrollment or recertification. And so when connectors don't have access to those electronic notices, that can cause issues. And otherwise, when they do have, of course, the electronic notice, they're able to reach out to their client and make sure that anything that's required gets submitted before the deadline passes. So that's been an issue that we've been working on. A few other system issues include problems with updating name and address, enrollment errors for legally residing immigrants, and complications with assisting people who have certain income changes or tax issues. And so these are problems we've been reporting to DMS and to the Kentucky Health Benefit Exchange. And I think that they're all being investigated, and some solutions or fixes are already in place, but we're monitoring these pretty closely. Another problem that has exacerbated the rollout has been staffing shortages at DCBS that have caused long wait times for the call center. And there's also been confusion about there being 2 numbers that people are being given at times for enrolling in Medicaid or a marketplace plan. There's one number that is specifically the Connect call center, and that's where you would call for any type of health coverage, so Medicaid or marketplace. And then there's the DCBS call center that you can call for all other benefits, and that also still includes Medicaid. And so we want to make sure that people are aware, especially providers, talking with the folks that are on this call, are aware that if people are calling right now related to their coverage, they should really be starting at that Connect line, because that alleviates some of the pressure on DCBS. And that's the 855 Connect number. And shortly after open enrollment began, connectors also started hearing from their clients enrolled in Medicaid who were receiving very confusing and concerning notices that indicated to them, as they were reading it, that their Medicaid coverage would be ending at the end of 2021, and that they're now eligible for a marketplace plan beginning in 2022. Now, that is not what the notice meant to communicate. So just to be very clear about that, but you can imagine the panic that many people were feeling, thinking that they're going to need to purchase a plan for themselves or for their families when they have very low incomes. So again, this is something that has been reported. There's a change being made to that notice to clarify, but I think it's important just to get the word out so that providers and others who are serving Medicaid members, interacting with Medicaid members, know that these notices have gone out. People may think that they're going to lose their Medicaid coverage, and we need to reassure them that that's not going to happen unless they no longer are eligible for Medicaid, but that's not what the notice means. So we're trying to make sure that that clarification gets out far and wide. So as I said, we've been tracking all of these issues, reporting them. We really appreciate how quickly the cabinet responded to some of these concerns, especially about that notice that I just mentioned and the work that they're doing to correct it. Other system issues are also being investigated. We hope that they'll be fixed before the end of open enrollment. We think that once some of these issues that kind of initially happened with the rollout get fixed, that we are going to have an integrated and very seamless system where people who have Medicaid or marketplace coverage, but then experience a change in their income throughout the year, which happens to, we've heard and estimated about 50% of people can easily move back and forth between Medicaid and marketplace depending on their income. And we think that's going to be very, very beneficial for a lot of Kentuckians. And you may already know this, but with enhanced subsidies on the marketplace, people whose income may go just above 138% of the federal poverty level are probably going to be eligible for a $0 premium plan. So it means that people are less likely to be uninsured at some points throughout the year when they have that fluctuating income, and that's really important. So for all those reasons, we want to make sure that we're fixing the system issues and making Connect the very best system that it can be. And we also did some brief updates on DMS's plans to unwind the maintenance of effort requirement that's been in place during the pandemic. And all that really means is how DMS is going to recertify households that are likely to have had changes in income, address, household size, maybe other things that have happened during the pandemic and need to be updated. And we know that a lot of people have moved and had address changes during the pandemic in particular. And so wanting to make sure that we have a lot of plans in place to communicate to people ahead of time that this is happening, that they need to update their address and other information, and also that we have a system in place where it's easy to do that. So we had that conversation. And I think that there are some processes in place that will help us to make that a little easier, but definitely something that we all need to be paying attention to and assisting with. And finally, we just briefly discussed the status of Medicaid's plans for the American Rescue Plan funding for home and community-based services. And we're really glad to hear that there are going to be some additional opportunities for stakeholders to get updates in December and also to have more input. And so just look forward to getting those dates so that we can get the word out. We didn't make any recommendations at our November meeting. We have one more meeting in December scheduled, so we'll probably be making recommendations then. That meeting is scheduled for December 14th at 1:30, and we did vote to approve our 2022 meeting dates. And so that's in the report as well.
Okay, thank you. Thank you, Emily. Anybody have any questions? Okay, thank you. Next up is dental.
Hello, this is Dr. Garth Bobrowski, and just I tried to be a little proactive, and I put the dates on chat for our meetings, and I'm embarrassed to say that I've messed 2 of them up. So I want to thank Ashima for having my back and getting me corrected, but I think we've got the dates on there. So I apologize if there's any mix-up. But our dental TAC did meet last Friday, the 11th. And we did vote to continue using the Zoom format through at least the first part of next year. We discussed some ongoing items that we are working on, and we really didn't have any motions to bring to the MAC this time, but we wanted to thank Commissioner Lee and Commissioner Veronica Cecil, and also Secretary Friedlander for meeting with us, in the KDA Executive Committee, to help with ideas and going forward on access to care and getting more dentists involved with Medicaid. So we're looking at some things and discussing those. I did want to report that one of our TAC members, who is an oral surgeon, it kind of in the more towards the eastern part of the state, which we only have about 2 and sometimes 3 oral surgeons that are seeing Medicaid patients for approximately the eastern half of the state. He has announced that he will no longer be seeing Medicaid patients after the first of the year, or at least by March. He wants to finish up, what patients he's already got booked. So that's a sad loss for that, because us general practitioners really need our oral surgeons for patients that have serious health conditions or on blood thinners that they can't be taken off. They just have to be seen by the oral surgeons. Let's see. I believe that completes my report. I'm just going through my list here. So thank you.
Thank you. Any questions? Okay, thank you. Next up is nursing home care.
Hi there, this is John Muller from the nursing home. Short report, because we did not meet. Our last meeting was September 8th. So we had this meeting after that, reported then, and did not meet. So thank you.
Okay, thank you. Home health.
This is Susan Stewart. We did meet, but we did not have a quorum and we had no recommendations. Thank you.
Okay, thank you. Hospital.
This is Russ Rinaldo. The hospital TAC did not meet. We will meet at the beginning of December. Thank you.
Thank you. Intellectual and developmental disabilities. Okay, nursing. Optometry.
This is Steve Compton. The optometric TAC met on November the 4th. We had a quorum. We had some discussions about just some minor issues, but we have no recommendation from the TAC.
Okay, thank you. Pharmacy.
The pharmacy TAC did not meet in October. That meeting, I believe, was canceled. The next meeting will be on December the 8th. So we'll be reporting after that.
Okay, thank you. Physician services.
This is Ashima Gupta. We did not meet. We will plan to meet January 21st.
Okay, thank you. Podiatry.
Still no TAC.
Okay. Primary care.
Good morning. This is Mike Cole. I'm the chair of the Primary Care Technical Advisory Committee. We met with quorum on November the 4th, 2021. Our next meeting will be January 6th, 2022 at 10 a.m. Our meetings are in Zoom and will continue until such time as the department is available to provide the necessary equipment for the hybrid type of meetings. We met, led in discussion by Mrs. Cecil and for the DMS. We were discussing the progress of the RAP work group, and we're waiting for the next meeting date concerning that at this time. The department has promised to prepare a PowerPoint document to provide or to help walk providers through the steps reference accessing into Kentucky Health Net. And it's my understanding, and from what was said at that time, that the equipment will probably be purchased, been selected, probably be purchased, be able to have the hybrid meetings around the first of the year, and probably by March should be in place. Also, following up on what Veronica said is that we had discussed with the department the preparing a crosswalk of vaccine benefits to be able to give out to those being vaccinated in the form of a laminated card or something to that effect, so that they can readily see what their potential benefits will be at the time of vaccination. And we did have a recommendation. Some of the board may remember that back on the meeting on May the 6th, I believe it was, of the MAC, that we presented a recommendation and withdrew it at that time because it had not been given to the board prior to the meeting, and also because the DMS had requested that we had done, while we had done a survey of 20 states, that we go back and include all 50 states in that survey. That has been done now. The 50-state survey, and the subject of this, the subject of this is the department's methodology on payment for multi-visits on the same day. Kentucky does not pay for multi-visits. They pay for one visit only, regardless. And the survey of the 50 states shows that this position held by Kentucky is in the minority. Including Kentucky, there are 8 states who only pays for one visit. Of the 42 remaining states, 23 states authorize 3 Medicaid payments for same-day encounters. Usually that is broke down to having to be a medical encounter, a behavioral encounter, and a dental encounter. Of the remaining 19 states, they authorize 2 payments, and usually that is for a medical encounter and a behavioral health encounter. Pursuant to the presentation that was done, a recommendation to be brought before this board was approved. And I would like to read that into the record now. The recommendation of the Primary Care Technical Advisory Commission is that the MAC directs the DMS to review their same-day multi-visit payment methodology and report back to the MAC, comparing Kentucky's methodology to that of its surrounding and other states to determine if Kentucky's approach is in parity with the majority of other states, and if not, to suggest an approach for Kentucky to become more mainstream with the trends across the country in reimbursement for same-day multi-visit payment methodology. And that is a recommendation to the MAC board from the Technical Advisory Committee for Primary Care in its in quorum meeting on November the 4th, 2021.
Okay, thank you. Any questions? Okay, then we'll move on to therapy services.
Good morning. I'm Beth Ennis, Chair of the Therapy TAC. I apologize. I'm covering from clinics, so there might be some background noise. Therapy TAC met on November 9th over Zoom. We did have a quorum. We're very excited that we have worked through some of the things with the fee schedule. We had reported previously that the 2021 fee schedule was posted incorrectly based on some last minute CMS changes. Instead of being a 10% cut, it was only a 3% cut. We finally got that worked through. And we did get word at our last meeting that all of the MCOs would be retroing to the correct fee schedule. We do have a little frustration in that one of the MCOs is requiring the providers to rebill every claim to get that reimbursement. All of the rest of them, including fee-for-service Medicaid, are simply reprocessing claims. So we're going to continue to work through that piece. The one other piece that came up that we're working through is related to our population of folks with intellectual and developmental disabilities. They've had a really rough time getting back into services from COVID, having things authorized appropriately that the therapists are requesting, because a lot of them had no service throughout the pandemic. They're not a group that would work well over telehealth, and they couldn't come in for services. So we're trying to work through those providers and DMS to look at the pre-cert and recert process for that group. We do appreciate DMS's response to our last request to the MAC on looking at the process of needing a physician signature for care. We do understand that it is part of the federal regs. I think one of the things that we're going to talk about at our January meeting is that there is a good faith attempt piece related to Medicare that we may request that they look at for Medicaid as well, because we know how busy the primary care folks are, and it sometimes takes a long time to get those requests signed and back before these folks can get seen. We will be meeting over Zoom in 2022. Our meeting dates were set and will be in our minutes, and we don't have any requests of the MAC at this time. Thank you very much.
Thank you. Okay, so that concludes the reports from the TACs. Would somebody like to make a motion to accept those reports and recommendations?
Steve Compton, I so move.
I'll second.
Thank you. Any discussion? Okay, all in favor, say aye.
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 Any opposed? Okay, so moved. Thank you, everybody. Next up on the agenda is our follow-up to the spring report on maternal infant health.
Hello, everybody. If someone could let me share my screen, I can pull my slides up.
Dr. Terrio, you are a co-host, so you should be able to share your screen.
Thank you. Now I just have to do it properly so you can see it. Can everybody see that?
Yes.
Wonderful. Well, I'm Judy Terrio, Medical Director for DMS, and we had spoke last, I think it was March, about maternal health, and this is a little update on that presentation. And just to set the stage, I just wanted to remind everybody that maternal death is defined as being pregnant within 1 year of pregnancy or while you're pregnant. And this has been going nationwide. It's the pregnancy-related mortality has been going up. And I did not show this slide last time, but I just wanted to let you guys know it's everywhere. It is increasing, not just in Kentucky, but it is increasing in Kentucky as well. And so the Department of Public Health, the Division of Maternal Child Health, has been charged with producing an annual report on maternal mortality. And the next one should be coming out soon. Most recent one was November 2020. And that report is developed from the Maternal Mortality Review Committee that is made up of a lot of different people. Some of them are Medicaid, DCBS, public health, BDID, law enforcement, CASPER, medical examiners, domestic violence folks. So there's a lot of people on this committee, and they go into depth about every maternal death that happens in the Commonwealth. And so it's a great deal of time that's put into this, but instead of just looking at the medical aspects, it looks at the whole person, which gives us a lot more information than just going off, a death certificate, things like that. Kentucky has about 25 to 26,000 births per year on Medicaid. And when we look at that breakdown, it's usually 70 or 67% white, 14% Black, 3% other, and unknown is 11%. And when we look at ethnicity, about 5% of our births are of Hispanic origin. And thinking back to that national slide, you can see Kentucky's numbers are creeping up with maternal mortality. And in 2018, we had 76 maternal deaths, which is really kind of shocking because these are young women that usually don't have a lot of chronic illnesses. The CDC nationwide says that about a third of deaths occur while the woman is pregnant. About a third occur from birth to 1 week postpartum, and then the last third is between 1 week and 1 year postpartum. So you can see that different approaches to these different times in a woman's life, you need to kind of attack all of it to try and make a difference. When we look at our numbers, we see that about 80% of our deaths are preventable. National numbers, when you look at that, it's right around 60% or a little bit more than 60%. But I think our numbers are more telling because we go into such detail when looking at the cases. And substance use contributes about 50% to about 50% of our deaths in Kentucky. So not surprisingly, this is still a big issue. Just touching on equity, when you're looking, and these things have not changed over time, these are national numbers from the CDC. Black women have much higher pregnancy-related mortality than any other demographic. And that hasn't changed that much over the years. When you look at Kentucky numbers, again, the rate of maternal deaths for white women, 17.2, which is around the national average, and rate for Black women is 42. So huge, huge increase. That's a big disparity. Again, the nation has this disparity, so Kentucky is not unusual in that. But if you think about it, these women are being cared for in the same hospitals with the same doctors and within the same system as the white women, and yet we have this disparity. So we have to work on that. And again, 2/3 of our deaths occur in the postpartum period, and a major driver is substance use disorders. And so thinking about what can change to make things better, one intervention would be to increase both the quantity and the quality of that postpartum visit. That's where screenings happen. That's where case management and care coordination can happen, linking people to resources. And so even nationwide, we think that this is a good place to try and make an intervention. Just wanted to give a nod to our MCO partners. They are aware of these numbers, and they have wonderful, all of them, high risk neonatal and maternal programs, and then incentive programs for pregnancy to attend visits, attend the postpartum visits and get incentives. So there's a lot out there to help encourage our patients to go in and get the care. So Kentucky was one of 9 states chosen to participate in the postpartum care affinity group but through CMS. And the goals of this group, this was last year, were to develop quality indicators to improve the quantity and quality of postpartum care, to increase attendance at postpartum visits, and to increase the utilization of long-acting reversible contraceptives for this population. And if you think about it, the postpartum care visit really, thinking about that 6-week visit, is the opportunity to assess the woman's physical recovery from pregnancy and the childbirth, but also to address any chronic conditions that are ongoing. Some women develop diabetes or hypertension while pregnant, and that's the start of their chronic condition. So getting the women into a pipeline to care for these conditions is the kickoff site, is that postpartum visit. Of course, you're going to address mental health status, postpartum depression, family planning, including contraceptions and spacing pregnancies to ensure the best health for mom and the next baby when people are ready for that next pregnancy. It's also nutrition, breastfeeding, addressing other preventive health issues that the mom may need, and linking moms to resources or to care management that is needed. So a lot of things hinge on this visit. So looking at our numbers, this is Kentucky Medicaid numbers. We see about 60% of our moms attend that postpartum visit. And this slide goes back to January 2018. I could have extended it several years more in the past, and it would not have changed. It is right at 60%. So our affinity group, we set a goal of 75% to try and get 75% of our moms to this visit. And which sounds good on paper, but then when you put it in a graph like this and you look at it, you kind of think, well, that's still not good enough. But we got to have baby steps, and we got to move towards to improving it even just a little before we can improve it all the way. Now we've been doing the same thing. So Insanity is doing the same thing over and over again and expecting different results. So you looked at that run chart, it just keeps going back for years and nothing has changed. So I think it's really time to make changes in the system to try and make improvements. It's not going to improve if we don't do changes. So one of the things that we've done with the affinity group is we've gotten together stakeholders to kind of learn what other people are doing, learn what our community partners are thinking, or what are the barriers, what are successes, what's working. And so we've got our MCOs on board, different parts of the cabinet. We've got the Perinatal Quality Collaborative and the Maternal Mortality Review. Also have people from Kentucky midwives, community organizations, primary care. And so trying to get an all-around view of what's going on. One of the surprises that we learned was the women in Louisville that are cared for at FQHCs, they receive their hospital care from a different provider than their prenatal care. And so you can see this is inherent. Okay, now the baby's born, where do I go? Do I go to this doctor that took care of me for 9 months? Or do I go to this doctor that delivered the baby? It's a little confusing. So when I look at that, I think that's a communication issue. We need to do better communication. We also learned that MCOs have difficult times learning when patients are pregnant. And a lot of it is based on claims. And so they have these great programs that they can reach out to women, but they can't reach out unless they know they're pregnant. And so there's a delay there. And we didn't think that actually would be a problem. You kind of assume they know this stuff. And so that was a surprise for our group that, so there's little things that we can do. And again, this is a communication issue as well. It all comes down to communication. So that stakeholder group has come up with different things to test. So maybe making the postpartum visit appointment prior to discharge and then following up to see if it was kept, creating a standardized notification of pregnancy form for the MCOs, utilizing community health workers to help support women prenatally, but as well as postpartum. case management for high-risk moms, doula services to support moms during and after pregnancy. This is under consideration as well. Encouraging placement of long-acting reversible contraceptives and explaining the need for pregnancy spacing to have healthier moms. We've also considered asking our MCOs to report monthly about the beneficiaries who attend the postpartum visits and just get some ongoing information so we can see where we need to target interventions. And again, exploring how we can get more postpartum care. We're considering providing postpartum care through 1 year postpartum. That's under consideration. And then exploring maybe different incentives for providers. Now the patients have incentives to attend the postpartum visit, but thinking about perhaps incentives for providers to get women to those visits. And this has been done in other states and has had really good results. So one of the things that we've been looking at is our PRAMS data, which is Pregnancy Risk Assessment Monitoring Program. It's a CDC program. And these are Kentucky results. And we called women back after they had their babies and asked different questions. And so this is what was done during the postpartum visit. Well, about 50% of them talked about or were prescribed birth control. 63% they were asked about smoking. 88% asked about depression. Now, if you look up, what is done at a postpartum visit, all of these things are supposedly done, but when we ask the moms, we got variable results. And then when you asked about birth control in particular, 2.7% of the moms said, no, I don't want birth control because I want to get pregnant, again. But of the moms that did not want to get pregnant again, these were the birth control choices that they decided on. And you can see about 23% chose condoms, 17% the withdrawal method, 10% said abstinence, and 5% said rhythm. That's over 50%. So in my idea, if you don't want to get pregnant again, and you're telling your doctor that, but these are the methods you chose, I'm curious about what that conversation is with the doctor. Part of me thinks it's a checkbox. It's like, I asked them about birth control, check that off, move on, versus actually having a conversation. What's the big deal? Why? Now, some of this is probably religious, but not that much. If you don't want to have a baby right away and you're discussing birth control options, it's important to discuss when you want to have a baby. Let's talk about that birth spacing. Why is it important to have spacing, for the mom and the next baby? And so it's more of a conversation and less of a checkbox. And so when I see this anyway, personally, I think that the postpartum visit needs to be kind of geared up a little bit for our moms and explaining why we're asking these questions. We've talked about certified professional midwives, and we are still considering including the CPMs as a provider. We're not ready to move forward at this time, but this is part of what the overall plan that we are considering for improving maternal health in the Commonwealth. Another thing, getting back to the equity issue, is implicit bias. Again, we have such higher rates of Black women having maternal mortality than white. And again, it's the same hospitals and the same providers and the same hospital systems. And so training people that take care of pregnant women and parenting women with implicit bias training, ACEs training, is really going to help. I mean, not that there's, a doctor or a nurse that is racist and causing, I'm not saying that, but I think our system is set up to care for African-American women differently from white women, and that's causing this disparity. And so we need to examine the implicit bias in healthcare professionals and in the healthcare system. So this was just a little bit more about the maternal mortality review, the affinity group that we're working within, and talked a little bit why the postpartum care visit is important in ways that we probably can strengthen it. And we touched a little bit on health disparities. Do you guys have any questions?
Thank you. This was very helpful. And I appreciate the information, time that you've taken to bring that to us. Does the council feel it would be important maybe here to have another update to see if any of these interventions have helped?
This is Ashma Gupta. I think definitely we want to see how it's progressing over time.
Okay.
This is Dr. Bobrowski. I'd like to find out more information about the, you mentioned the implicit racial biases in the healthcare delivery system. I just like to know a little bit more about the specifics on that.
We've been looking into that a little bit with the group, and it's implicit bias training is basically having people recognize their own bias. We all have bias, you know, for or against different things. Not that it's a conscious bias, but that may affect how patients are treated. And we might have bias against or people with substance use disorder. You know, you might have, you know, an initial and thought and treat people with substance use a little bit differently than somebody else. So you have to recognize it. I mean, it's normal to have them, but you have to recognize it. And so you can address it within yourself to make sure that you're being non-judgmental and treating everybody the same. We talk about equity, you know, because we learned that equal was a bad word, right? We learned we don't want equal, we want equity. But we also, when we're looking at like the PRAM survey, we've learned that like substance use, for example, 90% of the women screened for substance use had substance use disorder. So that doesn't mean 90% of our moms have that. It's just that 90% of people screened, which means you're only screening people that you suspect have a substance use disorder. And that's not how screening is supposed to work. You're supposed to, you know, do everybody and then and treat them equally. So part of the issue is, you know, we think equal, we don't want to, you know, treat people equally because we want equity and everybody's different and they need something different. But in doing that, we're kind of cutting off our nose to spite our face. So going back to postpartum depression screening or resource screening or things like that, you really have to screen everybody with a validated tool to learn who needs what and to treat them the same. So it's crazy that this is research nowadays that we're learning. I guess we're learning more about ourselves and the ways our minds, you know, think and do things. But just kind of opening your mind to you know, treating people equally and treating people within the same system will help decrease the health disparities.
Thank you.
Dr. Terrell, does the committee that has been established have any plans for implementing some of the recommendations that they've come up with?
Yes, and we do have plans, and because I don't know if I said this, about a fourth of our Medicaid moms are cared for in FQHCs or rural health clinics. We were thinking of trying to start some of the initiatives in FQHCs to see if they improve the outcomes. So we may be contacting you.
Okay, thank you.
Thanks.
So if it's agreeable with the council, we'll have an update next year to see how these things have changed or if they have changed. Is that agreeable to everybody?
Yes.
Thank you. So we'll put that on the agenda. So next year at our November meeting, we will have an update on all these things to see if anything's changed. Okay, moving on to new business. I have, my billing company has told me that Aetna is not covering the administration of COVID vaccine boosters. Is somebody from Aetna on this meeting that can speak to that?
This is Cindy Arflack from Aetna. Can you hear me?
Yes.
Okay. We apologize for this because there was a change in our system and it did not make it through before the claims started coming through. But it has now been, the change was made and we should reprocess those claims. But we by no means are not we are covering the vaccine booster, and we are committed to making sure that our members get the COVID vaccine and the flu vaccine. We want both of those. So.
Okay, thank you. So you're going to go back and relook at those.
Right. Yes, we should. There should be no problem. The change, it was just a timing issue, Dr. Parton, and I apologize for that. But
okay.
Yes.
Okay, thank you.
You're welcome.
And then somebody had told me that WellCare was going to begin mandating copays beginning in January. Can anybody speak to that?
Yeah, this is Stuart Owen from WellCare. Have absolutely no idea where that came from. We lobbied to get rid of copays for 2 years. We've been all against it. So I have no idea where that came from. It's not true at all. We didn't have them this year. We're not having them next year.
Okay, great. Thank you very much.
You're welcome.
Does anybody else have any other new business that they would like to bring up?
Yeah, Chair Parton, I do. This is Barry Martin.
Yes, go ahead, Barry.
Just have a question for DMS in regards to the new requirements to prescribe brand name drugs instead of generics. And I understand that there's rebates involved, but just kind of, we're trying to find out to follow how the rebates are applied, when are they applied, and like when we give a prescription to a patient and they go to the pharmacy and say if they're a WellCare patient, does WellCare pay the full amount for the brand? And is that going to be charged through our medical loss ratio? How does that be? How are those being accounted for through this process?
Hi, this is Veronica.
Hey, Veronica.
Couple of things. So first of all of our preferred drugs, so when we prefer a brand over a generic, all of that goes through the P&T committee, and those decisions are made at that level. And what they take into consideration, obviously, is efficacy, but they also look at cost to the program. So they have available to them information that shows if we went with the brand name drug with rebates and supplemental rebates, what the ultimate cost is to the program. And so those are why those decisions are being made. When it comes to the your question about does the MCO pay for the full cost of the drug, and that's correct. Yes, so that the drug ingredient costs that the pharmacy claims for reimbursement is what gets passed on to the MCO. You know, the dispensing fee that we went to was to take into consideration the cost of dispensing that drug plus the cost of the drug ingredient. I understand that sometimes, and particularly those at point of sale, pharmacies at point of sale, see that the generic may look less expensive, or a profit could likely be made more on a generic. But really, from a program standpoint, that's not really what happens for Medicaid. So those are the decisions that go in. We're good stewards of the taxpayers' money. We obviously are always looking to ensure that we're being cost efficient in the coverage of the drugs, and so all of that goes into the decision.
Yeah,
So-
and Veronica, oh, sorry. If
Go
I
ahead.
can just jump in here.
Yes.
So Barry, this is Fatima from DMS.
Yeah.
I want to make it clear that the pharmacy is getting the brand reimbursement at the end of the day. So whatever that falls into based on our lowest of logic. Essentially the pharmacy will get the brand reimbursement at the end of the day for dispensing brand.
Is just a quick question, is information that goes into making that determination something that we can look at closely? I'm just concerned from the pharmacy standpoint is the cost of goods for them to put that on their shelf is greatly increased.
Yeah.
And that's going to have an impact on the pharmacies as well. And so I've already had a lot of people talk about this, that it's going to, cause a great burden on many pharmacies because they're purchasing that for so much more that, their cost of goods has gone up considerably.
So are you
Well, and-
referring to the rebate piece of it?
I'm sorry?
Are you referring to the rebate piece of it that you'd like access to?
No, not necessarily. It's just that you're, putting a product that you may have been able to purchase for, I don't know, I'm just throwing it out there, $30 for 100 and you're being asked to pay in the hundreds and hundreds for it. So that causes a burden on the pharmacies from the standpoint of their cost of goods sold, of what's their inventory they're carrying. That makes sense.
Yeah, that makes sense. I think a lot of it is a matter of cash flow, right? So the pharmacy pays, let's say $2,000 or $200 for a brand upfront. They don't get that reimbursement until the claim is filed and submitted. So essentially the money does flow back to the pharmacy, at the brand rate. And, it essentially comes back to the pharmacy, but it comes back a little bit later. And that's one of the reasons why we went with, pharmacies getting paid on a weekly basis. So essentially that piece should help pharmacies.
But in years past, and even now, commercial insurance carriers encourages providers to write generic drugs. And Medicaid has done that in the past. Now we've flipped.
So Barry, in fee for service, which if you recall, we did move to align for ease of implementation, the fee for service program. We have always pretty much preferred brand because of the rebates. And I get that you all don't see that from your position, but we do. And so those are the decisions that we're making is based on that, the end cost to the program, is the rebate does make that brand cheaper for us.
So the state gets a different type of rebate than, say, a commercial carrier would get to make it cheaper to do brand
That's
versus
correct.
generic.
Yeah,
Okay.
you can't compare
So,
the two. Yeah.
I guess the other thing that I'm concerned with in years past, we are unable to get rebates applied towards our medical loss ratios with the MCOs. Now that will be even harder and more impactful. So how will that piece be taken care of by the MCO? Because the MCO is going to be out more money as well.
I can't speak to your payment arrangement with the MCO. You know, again, I mean, we have to make our decisions based on the cost to the program.
Right.
And the other thing I want to mention is, you know, January 1 was single PDL. July 1 was the single PBM, but we are evaluating, you know, right now, almost on a daily basis, you know, the impact to the program from both of those initiatives. So this is going to continue to evolve. We're learning about, you know, what's working, what's not working. We want to reform the pharmacy benefit to make it, you know, more sustainable and to give members access to the drugs they need, to remove administrative burdens. So, you know, we're continuing to evaluate that, and this is just kind of the first steps towards making some additional changes down the road. And we'll take
Okay.
all of this into consideration.
Okay. Is there any way that we could see that impact, financial impact, being performed as it progresses?
I'm not sure I understand the question. Sorry.
Is there any way that we can see what kind of a financial impact we're having on our pharmacy costs? I guess our concern is that, you know, we're going to be penalized by the MCOs for a larger MLR for these drugs if these rebates aren't accounted for, you know, on the back end. And that's one of our concerns.
Well, I'll be honest, I'm not sure how the MCOs are going to hold you guys accountable for something that's out of your control.
They do.
Because, you know, that was prior to January 1 and July 1. And so I think that conversation probably needs to happen between you all and the MCOs about what the program has changed, obviously. And so maybe that should change, but we're not going to get into the middle of that. But yes, so we absolutely plan to do a 6-month evaluation to take a look at, you know, what the impact of the single PBM has made to the cost, and we'll also show, you know, rebates as a part of that. But you know, I do know that it was very clear from the legislative intent was, you know, to align, to streamline, to make it consistent, to provide, you know, a dispense fee that's quite a bit higher than what you all were getting under the managed care organizations. And you know, we continue to look at it.
Okay. Yeah, if you don't mind, maybe we could look at those numbers. And then I think from the primary care's perspective, then we need to look at that and be able to go to the MCOs and talk to them about these rebates being kind of a reduction of our MLR as well.
And I just don't know, in full disclosure, I am not sure what we can share specifically about the, you know, our agreements with the manufacturers on the rebates. I just don't know what's public and what's not.
Okay.
But we want to be transparent, and certainly would be reporting out definitely the overall. I know we report kind of at a high level the amount of rebates that we get. We do share that information.
Okay. I appreciate it. We could talk more about it.
Barry, do you need this to be on the agenda, or are you going to just address this privately with the?
I'll just address it privately.
Okay,
I thought I needed to ask and in this forum as well, just in case any other people, the timing issues for pharmacies, that is an issue, but of course, quicker payment helps alleviate that. But maybe another concern would be is the supply of brand versus generic. Are the manufacturers going to produce more brand now to help, because we're kind of switching gears?
Right. And I encourage everybody that has concerns or wants to learn more to attend the Pnt meetings. We have a web page that has the meeting dates and the link to how to participate or virtual. But that's where those decisions go in, are discussed, and we get our direction basically from that for the preferred drugs.
Okay.
And speaking of Pnt, so our November Pnt meeting is actually today at 1 o'clock. I'm happy to share the link for the Pnt meeting, as well as the link to the Magellan provider portal. Sure, I'll do that right now in the chat.
Thanks.
Okay.
Thanks, Veronica.
Anybody else have any new business they'd like to bring forward? Okay, hearing none, would somebody like to make a motion to adjourn?
So
I'll make a
moved.
motion.
We need the dates. I'm sorry. This is the court reporter, the dates for next year.
Okay, January 27th, March 24, May 26, July 28, September 22, and November 17.
Thank you.
Okay. Anybody? We've got the motions. All in favor?
Aye.
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 Okay, so moved. Goodbye, everybody. We'll see you again
Okay,
next.
thanks.
Bye.
Bye.
Thank you all.